So hello, I'm Denise Hodson-Zingman. I am going to moderate this session, and it's my pleasure to introduce Dr. Barry London, who will be speaking today on cardiac genetics and heritable arrhythmias. And by way of background, Dr. London is professor of internal medicine and molecular physics and biophysics here at the molecular physiology and biophysics here at the University of Iowa, and is also our director of cardiovascular medicine and the Abood Cardiovascular Research Center and chair of internal medicine, or it has the Lambert-Botter Chair in internal medicine here as well. His MD and PhD are from Albert Einstein, and his residency and fellowship were done at the Mass General. And he also did a cardiac research fellowship at Boston Children's. He came to us several years ago where he was the chair of cardiology at the University of Pittsburgh and the director of the CV Institute at UPMC. And he's been our chair of, or our director of CV medicine here at the university for a few years now. And as mentioned, he is an expert in cardiac genetics and heritable arrhythmias. He has numerous NIH funded projects and too numerous to count publications on the topic. And so I'm sure we're going to have a very interesting and informative session here. And with that, I turn it over to you, Dr. London.
So thank you very much, Denise. I have nothing to disclose. Okay. So I'm going to start with a case, and this is actually how I got into the field. So this is the EKG of a 15-year-old girl who lived in the Western Boston suburbs. She had no cardiac history, no family history. She was sitting by the pool one day when her kid brother walked up behind her and poured a pail of cold water on her. Her response to that was to faint. Her parents witnessed it. She was unconscious for about 15 seconds, woke up feeling fine. Her parents took her that evening to Boston Children's, where she had this electrocardiogram done in the emergency room. Now, that was a time many, many years ago when patients in the ER were not necessarily seen by an attending. So she was seen by the senior resident in the ER who called this EKG normal. For those of you who are QT aficionados, you'll notice that the QT interval looks a little bit longer than normal. But the resident sent her home. He was, however, interested enough in the story that he gave her a Holter monitor and told her dad to have her write down any symptoms in the diary that he gave her. Her dad returned the monitor early the next week. This was the control tracing from the Holter, and if you count it out, you can see that her QT interval here is 600 milliseconds, which is obviously markedly prolonged. The diary that she had a single entry in it, and the entry was nightmare. And this is the rhythm that corresponded to her nightmare. So this is a classic example of a rhythm called torsade de pointe, or ventricular tachycardia with a rotating axis. So it looks like a sine wave in height. A number of questions that we don't know. Did the nightmare cause the rhythm disturbance, or did the rhythm disturbance cause the nightmare? Both are possible. Second question, how many nightmares did the resident who sent her home have? The answer is probably quite a few. But anyway, she has classic case of inherited long QT syndrome. And eventually, although at the time molecular diagnosis didn't exist, eventually she was found to have a mutation in a potassium channel called HERG. And we're going to talk about the inherited arrhythmia syndromes. Now, arrhythmias remain a major cause of morbidity and mortality, with well over 250,000 sudden deaths every year in the United States. Our ability to diagnose and predict who is going to die suddenly is not particularly good. And our ability to prevent it pharmacologically with drugs is also not very good. We do not have defibrillators that work well, but they are invasive and have a number of complications, interfere with lifestyle. Most arrhythmias are associated with structural heart disease. They're in patients who are having heart attacks, people who had heart attacks and have weak hearts and cardiomyopathies, people who have other causes of cardiomyopathies, non-ischemic with weak hearts. But there are these rare inherited conditions and they have taught us a huge amount about how the heart electrically works and what makes it electrically stable or unstable, conditions like long QT and Brugada syndrome. And that's what we're going to talk about today. This is a partial list of the inherited arrhythmia syndromes. They range from rare to extraordinarily rare. The most common are long QT syndrome and Brugada syndrome. We'll talk most about those, but there are short QT syndrome. There's also familial versions or inherited versions of non-inherited conditions like Wolff-Parkinson-White or atrial fibrillation. And here, the genetic, the clearly generic Mendelian inherited versions are extraordinarily rare. Now, in addition to the inherited arrhythmia syndromes, which usually don't have cardiomyopathies associated with them, there are a lot of inherited cardiomyopathies that are also associated with arrhythmias. And I won't talk about those today because Farhan Ahmed is going to give a talk about the inherited cardiomyopathies coming up. Okay, I want to say a few words about genetics and how to think about genetics. So, we all have DNA, and it's good to think of DNA as a code book. And it's a code book that tells the body how to put organs together. We have 3 billion our code book has 3 billion base pairs of DNA in it. So it's a book with 3 billion letters in it. And we have 2 copies of the book. And when we have a kid, we give 1 copy of the book to the kid, and our partner gives 1 copy of the book to the kid, and our kid has 2 copies of the book. These genetic conditions are typos. So when somebody had a kid, either the parents of the person who presents to us or somebody 10,000 years ago, they copied the book and they either added a letter, deleted a letter, miscopied a letter. And if that letter happens to be in one of the genes that controls the electrical function of the heart, you end up with these inherited arrhythmia syndromes. Once the mutation or the genetic mistake or the typo is there, there's assuming 1 copy of the typo causes the condition, which is the most common type, there's a 50-50 chance that somebody who is affected will give it to their kid. There's a 50-50 chance their brother and sister will have it, and they got it from one of their parents unless they're the first person in the family who has the typo. Now, when we talk about DNA variants or DNA mistakes, we have to distinguish between mutations, which cause disease, and all the other variants which don't cause disease. We all have millions of variants that distinguish each of us from each other. They're why some of us are tall, some of us are short, some have blue eyes, some have brown eyes, etc. The most common type of variant is single nucleotide polymorphisms, or SNPs, where there's just a different letter, in the DNA code. Mutations or variants can be inherited in an autosomal dominant way, where a single copy causes disease, or autosomal recessive, where it takes 2 mutant copies to actually cause disease. As you can imagine, recessive is less common than dominant because you need 2, copies of rare mistakes to have actually disease. There's X-linked, and we won't talk about that because really none of the arrhythmia syndromes are X-linked, like Duchenne's muscular dystrophy, etc. So mutations, as opposed to variants that aren't mutations, are always rare, because if it's common, you can't have 1 in 5 people having a genetic syndrome. So they're always rare. They're in amino acids that are conserved, meaning that they're present in all people and usually down all the way to zebrafish and flies and other smaller organisms. They change the RNA or the protein, and everybody in the family who has the disease should have the mistake, and people who don't have the disease shouldn't always have the mistake. Now, there are people who have the mistake but won't have the disease, and that's called incomplete penetrance. Polymorphism, so variants that aren't mutations, they can sometimes modify diseases, and we won't talk about that today. Genetically, one of the problems when we do genetic testing, so genetic testing is reading the book. So we read the genetic book for looking for DNA mutations that can cause these diseases. And we're about 50% good at reading the book and identifying the mutations. But we do identify a lot of variants of uncertain significance, which means that we find something and we don't know enough to decide whether it causes a problem or whether it's just something that's there that doesn't cause the problem. And we'll talk more about genetic testing, in a little bit. okay, why do labs like mine and cardiologists want to study rare inherited arrhythmia syndromes? Well, there's two reasons. One is, although these conditions are rare, knowing the gene and the mutation can actually help people in the families that carry them, and help people identify people at risk for sudden death and hopefully prevent it. In addition, we hope that by identifying the genetic mistakes in these rare conditions, we'll learn something about inherited arrhythmias, and that we'll be able to translate that to the more common types of sudden death and arrhythmias that happen in heart attacks and in heart failure. And that has been true, sort of so far. Okay, I'm going to spend about 2 minutes talking about the heart as an electrical organ, and I apologize, for the sort of electrophysiology involved. It can be a little bit painful. But the short version is all the cells in our bodies are batteries, and the inside of our cells are negatively charged about 90 millivolts compared to the outside of the cells. The reason for that is we have a sodium-potassium pump in the membrane of our cells. It pumps potassium in and sodium out. So intracellular potassium is 140 millimolar, blood potassium is 5 millimolar, while blood sodium is 140 and intracellular sodium is about 20. You then put proteins in the membrane called channels that are permeable only to a single ion, in this case potassium. Potassium is 140 millimoles inside, 5 millimoles outside. It goes down its concentration gradient, leaving behind a negative charge. Eventually, the negative charge is strong enough that it prevents more potassium from leaving. There's an equation called the Nernst equation that tells you where that equilibrium is. If you type in 140 and 5, you get minus 90 millivolts. So cells live at minus 90 millivolts. If you're a liver cell, you live your whole life at minus 90 millivolts until your host goes out drinking and you die and you go to 0 millivolts. And that's the electrical life of a liver cell. If you're a brain cell, a heart cell, a skeletal muscle cell, you use changes in voltage to signal. So you change the voltage in what we call an action potential in the heart. How do you do that? You close the potassium channels, you open a bunch of sodium channels. Sodium's 140 millimolar outside, 20 inside, sodium rushes in. The voltage goes from minus 90 up to about plus 20. You then close those sodium channels quickly. You open a few calcium channels, which lets some calcium in. You have a few potassium channels that let some potassium out. You sort of hang out for about 3/10 of a second. Then you open a bunch of new potassium channels and you go back to minus 90. This happens once a second in somebody with a heart rate of 60. The EKG, the electrocardiogram, is a surface representation of the spread of electrical activity through the heart. So electrical activity starts at the SA node. It spreads through the atrium. That is the P wave when half of the atrium is depolarized at plus 10 millivolts and the other half is still at minus 90. That's the middle of the P wave. When then the whole atrium is depolarized and you have isoelectric again, then electroactivity spreads into the ventricle, and that's the QRS complex where part and then all of the ventricle is depolarized. The ST segment is when the whole ventricle is depolarized at 0 millivolts, give or take a bit. And then the T wave is asynchronous repolarization of the ventricle back to minus 90 millivolts. Long QT syndrome, for example, the QT interval is too long. Why should the QT interval be too long? It could be too long because the action potential is too long. Why would the action potential is too long? Well, maybe the sodium channels that were supposed to close here didn't close properly, or the potassium channels that were supposed to open here to terminate the action potential didn't open properly. And that's the molecular basis of the majority of long QT syndrome. Now, the action potential is here to signal the release of calcium. So, and during the action potential, calcium channels open, which cause release of calcium from internal stores, which cause the contraction of the heart. You then suck the calcium back in, the action potential ends, and you reprime, get ready for another heartbeat. Okay, this is the list, a partial list now, of genes that cause long QT syndrome. They are potassium channels that don't open properly, sodium channels and calcium channels that don't close properly, and accessory proteins that help the potassium channels and the sodium channels work properly. There's more than 15 genes that have been identified that have mutations in them, but the only important ones clinically really are the top three, because they make up more than 95% of genetically identifiable long QT syndrome. They include KCNQ1, which is the most common cause of long QT syndrome. This is the gene that makes the action potential and the electrical beat shorter and QT shorter when heart rate goes up, when adrenergic activity is present. So people with mutations in this gene, which is about half of genetically identifiable long QT syndrome, they get in trouble during exercise, and stress tests can bring out arrhythmias in these folks. HERG, which is the other common potassium channel, causes about 45% of genetically identifiable long QT syndrome. And HERG mutations, which is the ones that the girl I presented at the beginning of the talk has, they cause arrhythmias with exercise, but also in response to loud noise and emotional startle. And the reason for that isn't fully yet known, but it's clearly true. These are people who wake up dead when their alarm clock goes off, or die when a doorbell rings, or when your brother dumps cold water on you. Finally, the sodium channel mutations, this is the main cardiac sodium channel, and mutations in this gene are associated with slow conduction and bradycardia. So people with sodium channel mutations tend to die at night, although pacemakers don't prevent sudden death. And like I say, all the rest, and this is about 3% of genetically identifiable long QT syndrome, and all the rest of these together make up only 1 or 2% of genetically identifiable long QT syndrome. So these are all ridiculously rare, while these are relatively common. Okay, so the mechanisms of long QT syndrome, they are either potassium channels that don't open properly, or sodium calcium channels that don't close properly. So how do the mutations cause disease? Well, you can have mutations in, for example, potassium channels that prevent RNA from existing, that prevent the RNA from making a protein, or you can make abnormal channels. The channels can be non-functional, or they can open at voltages that just don't exist physiologically. For sodium and calcium channels, on the other hand, you need mutations that prevent them from inactivating, preventing them from closing properly, which leads to persistent late inward currents, which makes the action potential longer. As you can imagine, it's easier to figure out a mutation that's going to kill a channel than one that's going to keep it open. And so the potassium channel mutations are much more common than sodium channel mutations that cause long QT syndrome. I don't want to get into this in detail, but there are different types of mutations, and some mutations are more malignant than others. One example is here. It takes 4 functional potassium channel subunits to make a functional channel. So if you have a mutation that just eliminates the RNA and protein of one of the 2 copies of the gene that you have, you'll have half as much RNA, half as much protein, half as many channels. But if you have a mutation that causes a grossly abnormal channel that doesn't work properly, but still makes the protein, because it takes 4 of these together, a single mutation can take out 15/16 of the functional channel. And it's clinically known, although not clinically useful at the moment, that mutations that affect the pore of the channel and cause severe channel dysfunction are actually clinically much worse than mutations that just eliminate half the copies of the gene. Okay, so you have a mutation in one of these channels, you have long action potentials, you have a long QT interval. How does that actually cause arrhythmias? Well, these mutations do 2 things when we think of arrhythmias. They initiate and then they maintain the arrhythmia. So how do they initiate the arrhythmia? Well, in long QT syndrome, it's something called triggered activity, where the mutations lengthen the action potential, and lengthening the action potential allows the action potential, which is normally a sequential flow of ion channels where sodium channels open, sodium channels close, calcium channels open, calcium channels close, potassium channels open. If the action potential is long, you can end up with a condition where the sodium channels open and close, the calcium channels open, close, but then reopen again. So you can get a second action potential that's in top of the first, called early active depolarization. In addition, if the action potential is long, you get more calcium coming into cells, and you can get calcium overload, which then causes a spontaneous release of calcium from the internal stores after the action potential, and that's a delayed active depolarization. And all of these can cause PVCs. And once you have a PVC, you can form reentrant circuits in the heart. And the long QT mutations help make this happen, and they do it two ways. Some of the mutations can slow down conduction, especially the sodium channel mutations, and that can help allow these reentrant circuits to be stable. In addition, although the action potentials are long everywhere in the heart in long QT syndrome, in some areas, they're much longer than they are in other areas. So you can have areas where the action potentials are so long that the wavefront actually has block. So usually when we think of heart block or of conduction block causing arrhythmias, we think of a scar in a heart attack. But you can have areas where it's what we call functional block, where the action potentials are so long that they act as though there's a scar there and block conduction. And that can lead to stable reentrant circuits causing ventricular tachycardia, and these can then become unstable and degenerate into ventricular fibrillation. Okay, let's talk about clinical long QT syndrome. There's three types. There's the most common genetic type, which is autosomal dominant or Romano-Ward. This is where a single copy of a mutant gene causes long QT syndrome. Like I say, this is by far the most common genetic type of long QT syndrome. Now, if you're unlucky enough to have two bad copies of either KCNQ1, the long QT1 gene, or its helper subunit, KCNE1, you get a condition called Javel-Lange-Nielsen syndrome. And these people have really long QT intervals, well over 500 milliseconds. They have really bad arrhythmias. Oftentimes, you can pick them up in utero before the baby's born. And they have congenital deafness. Why are they deaf? Well, it turns out the KCNQ1, KCNE1 channel complex is present in two places, in the heart, but also in the inner ear. And you need some of that channel to make endolymphs in the inner ear. So if you don't have any of that channel, your inner ear is non-functional and you are congenitally deaf. And as you can imagine, the parents of somebody with Javel-Lange-Nielsen often have a mild form of Romano-Ward syndrome because each parent carries a KCNQ1 or KCNE1 mutation that they then give to their kid. Finally, there's a non-inherited form of long QT syndrome called acquired long QT syndrome. And this is mostly drug binding to the hERG potassium channel. So the pore of the hERG potassium channel, is promiscuous. A lot of different drugs bind to it. And so if you end up if you have, sort of barely enough potassium current to polarize your heart, and, and one of these drugs bind to it, you can end up with insufficient repolarizing current and acquired long QT syndrome. This is common. Probably 2 or 3% of our population is susceptible to acquired long QT syndrome if you get, exposed to the drug. And these include antihistamines, antipsychotics, some antibiotics, and an assortment of other drugs that can actually, sort of do it. Is this genetic? And the answer is no, it's not simply genetic. So looking for the genetic mutations that cause inherited long QT syndrome, if you do that in people with acquired long QT syndrome, drug-induced, you won't find it. So we don't do genetic testing for acquired long QT syndrome. Okay, so what are the symptoms of long QT syndrome? Well, fainting, sudden death, unexplained seizures. If you have no blood flow to your brain, one of the things that your brain can do is seize. And so sometimes people will be diagnosed with epilepsy and it'll only be picked up relatively late on that the epilepsy was really a result of ventricular tachycardia, ventricular fibrillation. Finally, sudden infant death syndrome. If you're a baby and you have one of these mutations and you have an arrhythmia and die suddenly, you get lumped into the SIDS category. And most of SIDS is thought to be a pulmonary issue, but from molecular autopsy, where you actually do genetics on babies who die suddenly, you can estimate that up to a third of SIDS is probably inherited cardiac arrhythmias, and oftentimes new mutations which their parents, didn't have. How do you diagnose long QT syndrome? Well, there used to be scoring systems that Peter Schwartz especially, had developed, where you got points for how long is your QT, do you have torsade, do you have macroscopic funny T waves, is your heart rate low, do you have congenital deafness, do you faint, are there people in your family, who have, sort of what appears to be long QT syndrome. We tend not to use these as much now that genetic diagnosis exists. And we'll talk more about the genetic testing in a bit. But still, clinically, you can make a decision whether you think somebody clinically has long QT. And since genetic testing isn't perfect, it's still important to be able to identify and diagnose long QT syndrome without the genetics. Okay, can you look at the EKG and tell what the gene is? And the answer is, for people who are good at it, they can get it right about 70 or 80% of the time. And here's how it works. So long QT1, this is KVLQT1 or KCNQ1 mutations. This is the one where the action potential doesn't shorten properly and the QT interval doesn't shorten properly at high heart rates. So at low heart rates, the EKG looks pretty normal. The problem is when the heart rate goes up, the QT interval doesn't shorten. By the way, when you look at an EKG, the QT interval should be less than or equal to half of the RR interval. And so here you can see this is about half of the RR interval. But if this doesn't shorten and the next EKG, the next QRS starts here, the QT interval will be the corrected QT interval will be markedly prolonged. Okay, long QT2, this is the HERG mutations, the same gene that causes the drug-induced problems. Okay, so these patients have funny T waves. So especially in the inferior leads and the precordial leads, V2 to V5, they have biphasic T waves, pointy T waves, flat T waves, funny T waves. Long QT3, this is the sodium channel mutations that are associated with slow heart rates. Here, the QRS is normal, the T wave is normal, but the ST segment is too long. So the QT interval here you can see is well over 500 milliseconds, but the T wave and the QRS are normal. It's just the ST segment is longer than it should be. Like I say, people who are good at this can look at an EKG and get pretty good at guessing what the genetic mistake is. Okay, how do you treat inherited long QT syndrome? Well, first thing is you tell people to avoid drugs that cause acquired long QT syndrome. You can imagine if your QT is already too long, the last thing you want is to take a drug that's going to take out part of your HERG channels and make it worse. The hallmark of treatment is beta blockers. So especially for the potassium channel mutation, especially for the long QT1, beta blockers are functionally curative. And so in the United States, if you have sudden death with a long QT1 mutation, you get beta blockers and a defibrillator. And the beta blocker of choice is Nadolol. If you're in Europe, you actually just get beta blockers, and you have to prove that you have arrhythmias on beta blockers before you get a defibrillator. They work really, really well. And so defibrillators are an important therapy, and they, aside from beta blockers, they are the, hallmark of therapy. And then the question is, who has enough risk to require a defibrillator? And we'll talk about that in a minute. And finally, sympathectomy, which is you're basically cutting the sympathetic nervous system, input into the heart. And so this is the ultimate beta blocker. It works really well. We don't use it much in the United States, but we do use it occasionally. We've done a few here. Like I say, it is used more frequently in Europe. Okay, so how do you tell who's at high risk? Well, so we have these pyramid things, and people at the highest risk are people who've had aborted sudden cardiac death. And the next group are people who are on beta blockers who are treated, but still have either documented arrhythmias or arrhythmic syncope. And these are people who have sufficient risk to warrant a defibrillator. Jervell-Lang-Nielsen syndrome is the autosomal recessive type with very long QT interval. Oftentimes we'll put prophylactic defibrillators in these folks. patients with the best predictor of arrhythmic sudden death turns out to be QT corrected, QTC interval. And if the QTC interval is greater than 500 milliseconds, you have a significant risk of sudden death, even on beta blockers. And so these are people one considers defibrillator therapy in. How about gender? How about age? Well, it turns out women have longer QT intervals than men after puberty. Before puberty, boys have longer QT interval than girls, and the sudden death risk goes along with that. If you have a baby and you're long QT2 in the postpartum period, you have a very high risk of arrhythmias, and that's something that needs to be taken into account. You need to make sure people are on beta blockers at that time. How about family history of sudden death? If you have a relative who died suddenly, does that predict that you're at high risk for dying suddenly? And the answer is no. There's sort of pretty good data that a single relative who died suddenly is not put somebody with long QT syndrome and plus minus a mutation at a known mutation at higher risk, from somebody who doesn't have a relative who died suddenly. That said, somebody walks into your clinic and said, I'm 23, I was just told I have long QT syndrome. My sister died at 21. My brother died suddenly at 19. My mom died at 18. At 22, right after she had the 3 kids. What do you think I should do? The answer is, what type of defibrillator would you like? There's no data that says that somebody who has multiple relatives with sudden death shouldn't get a device. And there's clearly malignant mutations that run in families and malignant families. So if you run into one of them, use common sense and treat them appropriately. We already talked about the EKG varying by mutation type. Are there other things? Well, we talked about the trigger of the arrhythmias. So long QT1, this is the mutation that shortens the active potential with faster heart rate. Exercise triggers arrhythmias. These are the kids who die on a soccer field or during a pickup basketball game. Long QT2, we talked about noise and startle causing it. Long QT3, we talked about rest. I mentioned there were more malignant mutations. We talked a little bit about dominant negative and poor channels. How about gene-specific therapies? Well, we talked about beta blockers that work best in long QT1, somewhat in long QT2, and maybe not at all in the sodium channel long QT3. How about other therapies? Well, it turns out that the hERG potassium channel is activated in high extracellular potassium, and shut down in low extracellular potassium. So can you, basically raise blood potassium by giving people potassium and spironolactone? So the answer is yes. Can you shorten the QT interval by doing that? Yes. Is there evidence that this prevents sudden death? The answer is no. Long QT3, the sodium channel mutations, there are some patients where mexiletine and other sodium channel blocking drugs actually block the mutant channel better than the wild type channel and will normalize the action potential, will normalize the EKG. Is that good in people who have malignant arrhythmias with long QT3 mutations? Absolutely. Is it an alternative to defibrillators? Absolutely not. Again, there's no evidence that you prevent sudden death, certainly prophylactically, as primary prevention using any of these drugs. So if somebody's at high risk, they get a defibrillator, at least they're often one. So to summarize, long QT syndrome is a disorder of repolarization. A limited number of dysfunctional potassium channels cause it. Also, sodium channels that don't close properly or inactivate properly cause it. There are genotype-phenotype correlations that exist and may lead to gene-based treatments. And this has catalyzed a huge amount of work that's led to our understanding of the role of potassium and sodium channels and calcium channels in maintaining stable rhythms in the heart. Okay, on to the other conditions. If you like long QT, you'll love short QT syndrome. Long QT syndrome, not enough repolarizing potassium current. Short QT, too much. Mutations in the same potassium channel genes that keep them open and cause too much current, or in calcium channels that close them and don't lead to enough inward current. Here's an example of an EKG with short QT syndrome. This is not subtle. The QT interval here is about 280 milliseconds. Very pointy EKGs. If you have this short a QT interval, it is highly arrhythmogenic. More recently, though, more mild cases have shown up with a QT. Corrected QT is below 380, but not ridiculously short, and these are not as arrhythmogenic. Again, the only real therapy for this is a defibrillator. We do have drugs that cause acquired long QT syndrome. Can we normalize the EKG a bit by giving you a toxic dose of sotalol? Absolutely. Does it actually prevent sudden death? We have no idea, and it shouldn't be used as primary prevention. Reasonable to try it in somebody who's having multiple defibrillator shocks to see if we can decrease the number of shocks. Okay, on to Brugada syndrome. So this is the EKG. This is a typical Brugada syndrome EKG. 55-year-old guy who was having lunch in Erie, Pennsylvania, with a colleague when he fainted into his egg salad sandwich. No medical history, no family history that he knew about. Was taken to a local ER. They said, you're having a heart attack, you have a right bundle with ST elevation, it's an anterior wall MI. He said, I'm not having any chest pain. They said, you need to go to the cath lab. He went to the cath lab, had squeaky clean coronary arteries. They did an echo. They sent him down to Pittsburgh for an MRI, where the head of VP in Pittsburgh at the time identified this as at what at the time was called right bundle branch block ST elevation syndrome, a condition that is present, that's inherited and can cause arrhythmias, that has since been named Brugada syndrome after the Brugada brothers who described this. At the time, he was seen by a cardiologist, Raoul Weiss, who offered him a defibrillator and placed the defibrillator. 6 months later, he was feeling poorly. Maybe a viral illness was being driven down to Pittsburgh by his wife for an appointment, when he fainted twice in his car. And this is the rhythm from the telemetry from the defibrillator when he fainted. Very rapid polymorphic VT, VF, 2 shocks back to sinus rhythm. This brings out one of the problems with the inherited arrhythmia syndromes. So this was 20 years ago. He is now 76 years old. He has had no further events. So he is a 76-year-old guy who has had this inherited syndrome his entire life. He had 1 fainting spell at age 55 and 2 aborted sudden death episodes at age 56, and absolutely nothing else. And we know he's had nothing else because he has a defibrillator, and the telemetry has shown nothing, for the rest of it. So these are rare, even though he has susceptibility to sudden death. The trigger events don't happen often. It's really hard to study something that happens 3 times every 76 years. And so that's something we don't understand, the trigger events. Was it the egg salad sandwich? Was it a cold that he had, etc.? These are the genes that cause Brugada syndrome. There's a lot of them, and they're not as clean as the long QT genes. And I'll explain that in a minute. So Brugada syndrome is a sodium channel deficiency syndrome. So long QT, sodium channels that don't close properly. Brugada syndrome, not enough inward sodium current or not enough inward calcium current. So not enough inward current. The only gene that by itself can clearly definitively cause Brugada syndrome mutations in the cardiac sodium channel that take out at least 50% of the inward sodium current. The others are all sodium channel, or mostly inward current modifying genes, like GPDN1L, which our lab identified, which is sodium channel trafficking gene. But by themselves, they probably don't eliminate enough of the sodium current to cause Brugada syndrome. So you need more than 1 mutation. So Brugada syndrome is inherently polygenic. And so genetic testing isn't as good. And the only real genes that usually identify are mutations in the cardiac sodium channel, although there's a number of other putative Brugada syndrome genes. So Brugada syndrome, right bundle branch block ST elevation leads V1 to V3. It's autosomal dominant. It is male predominant, meaning most of the case, about 80% of the EKG patterns and sudden death happen in men. There's minimum structural heart disease, although there can be a little picked up by MRI or by autopsy. And this is most common in parts of Southeast Asia where it is the most common cause of sudden death in young men in some villages in Thailand, Vietnam, Southeast China, parts of Japan. In some of the villages in Thailand, this led to an interesting finding or an interesting practice where it's known that it's more common in male than with females, and the sudden death usually happens at night. So young men and affected families will dress up as women before they go to bed on the hope that they will fool the gods that lead to the sudden cardiac death. A general statement, there's no randomized controlled trials in any of these inherited arrhythmia syndromes looking at therapies. Similarly, there's none in to see whether a guy dressing up as a woman at night will prevent sudden death. My guess is it doesn't work, but again, not proven. As I mentioned, genetic testing isn't as good in Brugada syndrome largely because it's probably polygenic. It's only about, you can only identify about 30% of the mutation of causative mutations in people with Brugada syndrome. There's gene modifiers that have been identified, also common in polygenic conditions. You can have overlap syndromes where you have a long QT syndrome and Brugada syndrome from a sodium channel mutation. So too much late current, the channels don't close probably, but not enough current overall can give you either or both at the same time in the same person. And I mentioned that the genetic testing doesn't work as well. Symptoms are the same as long QT syndrome: syncope, sudden death, unexplained seizures, sudden infant death syndrome. I won't spend a long time about the mechanism of the ST elevation, but the bottom line is if you have a mutation that gives you not enough sodium channel, you can end up with really short action potentials in parts of your heart or really slow conduction to parts of the heart. So you end up with part of the heart having an action potential, part of the ventricle being depolarized, and part of the ventricle not being depolarized. And that is electrically unstable. You have current flow, you can get initiation of PVCs, and you can get initiation of ventricular tachycardia and ventricular fibrillation. Okay, how do you diagnose Brugada syndrome? Well, the symptoms, the EKG pattern. It comes in two flavors, cold versus Salbeck, and I'll show you those in a second. It's a sodium channel deficiency syndrome. So we can bring it out by giving people sodium channel blockers. In the US, we give IV propanamide. In Europe, they use IV ajmaline, which is much more powerful sodium channel blockers. You can exacerbate the EKG findings. You can cause arrhythmias, which are prognostically bad. There's also conduction disease, which is common in sodium channel mutations. So you can do EP studies and look for conduction disease. Patients with Brugada syndrome, are more susceptible during program stimulation in an EP study to inducible ventricular fibrillation, but it's debatable whether that's clinically really useful. And genetic testing, we talked a little about, we'll talk more. This is the EKG patterns. This is the diagnostic pattern in leads V1 to V3, right bundle branch block pattern with coved ST elevation and an inverted T wave. There's also type 2 and type 3, which are saddleback patterns. Saddleback because you can sort of make the saddle, you can sit in. So this, but with an upright T wave. 2 millimeters or more of ST elevation is type 2, less than 2 millimeters is type 3. These are not diagnostic because these patterns are rare, but not that rare in seen in people, especially in young Black men. You can see this pattern in leads V1 to V3 relatively commonly. What you do is if you have somebody and you're suspicious, you give them a propanamide challenge. And if you turn this pattern into this pattern, it's diagnostic of an EKG. It's diagnostic of Brugada syndrome by EKG. The other thing is you can raise the location. Usually we do leads V1 and V2 on the EKG in the 4th intercostal space. You can go up to the 3rd or the 2nd intercostal space. And if you bring out this pattern, it's diagnostic of Brugada syndrome. Okay, how do you treat Brugada syndrome? Well, avoid sodium channel blockers. It's easier than avoiding acquired long QT drugs because there aren't that many of them. If you're at high risk, you get a defibrillator. And then the question is, who's at high risk? And the answer is that if you have a type 1 pattern and syncope or documented arrhythmias, you're at high risk and you get a defibrillator. If you have aborted sudden death, you get a defibrillator. If you have Brugada syndrome and arrhythmogenic syncope or arrhythmias, then you get a defibrillator. The hardest question is you have a type 1 EKG pattern, which is known to put you at high risk, but no documented arrhythmias or syncope. Those people sometimes are offered defibrillators, sometimes not. And finally, you have, if you have only a genetic diagnosis or it takes a cocainamide challenge to bring out the condition, those people are at low risk and they don't get a defibrillator. So Brugada syndrome is a misbalance between inward and outward currents. So people have come up with the idea of using quinidine to block the outward currents. Another case where you normalize the EKG, but you shouldn't do it to prevent sudden death because there's no evidence that you do. I'm going to give a couple of cases, that are, show things not just about Brugada syndrome, but about the inherited arrhythmopathies in general. So this is a case that we ran into in Pittsburgh, about 15 years ago. So Proban had a syncopal event, came to the emergency room, had a type 1 Brugada pattern. His syncope really sounded vasovagal, so people thought that he had a vasovagal pattern and syncope and just happened to have Brugada syndrome, but he was offered a defibrillator and accepted it. He's a nervous guy, and he has gone through 3 defibrillators, has never had a shock from his defibrillator, but is tortured by having his defibrillator. So somebody with a type 1 pattern, reasonably moderately high risk, gets a defibrillator, hasn't been useful to him. Okay, he had a sister who is crazy, literally speaking, DSM-5 psych diagnosis. She had a screening EKG, type 1 Brugada pattern. She declined consideration of a defibrillator, said we weren't allowed to talk to any of her kids and wanted nothing to do with us. Proban had a son at age 15. His son had syncope, sounded vasovagal, went to the ER, had a type 1 Brugada pattern. His was seen by pediatric cardiology. They didn't think he needed a defibrillator and thought that he should be followed. His sister had a funny EKG, not clearly Brugada, but funny, and was followed. Okay. So we identified a mutation in the cardiac sodium channel that affects sodium channel trafficking, and this is a clear causative mutation of Brugada syndrome. So now we know who's had it. Okay, so 13 years go by, and what's happened to the family? It's an example of we can know the genetics, we can know the clinical part, and our treatment still leaves a lot to be desired. So I mentioned the Proban. He's had a defibrillator for 15 years, never gotten a shot, never had a significant arrhythmia. Okay. His sister, who wanted nothing to do with us, her daughter in Florida had witnessed aborted sudden death, was fortunately resuscitated, had a type 1 Brugada pattern, has a defibrillator. Okay. The son reached 18, care was transferred to adult cardiology, was offered a defibrillator, declined. He was working on a car, was underneath the car, and had sudden death. By the time he was pulled out from under the car, he was unresuscitatable, so he died. Sister, shown to carry the mutation, was offered a defibrillator, accepted the defibrillator, has had no arrhythmias. So here's a case where we put defibrillators in the 2 people who didn't need them and didn't put them, at least initially, in the 2 people who did need them, and ended up with one actual sudden death. Another example of a case. So this is a patient over here. This woman presented to me. She was in her late 40s. She presented to me with a Brugada EKG after her second son died. So the story is her first son had witnessed sudden death, was resuscitated, but was brain damaged. and was living in an institution for the next 8 years until he eventually passed away. When he died, Mom told the 2 other siblings that they should get checked out. One of the siblings, his brother, went to a cardiologist, had a clear type 1 Brugada pattern. Cardiologist didn't recognize it as Brugada syndrome. Thought that it might be ischemic, did a stress test, which made it better, which is what happens. Did an echo, which was normal, told him he was fine. He had his first son at age 32. After he left his wife the day of the birth of his son, he went to a bar with a friend to have a drink, dropped dead off the bar stool, was unresuscitatable. At that point, Mom came to us. She had a type 1 Brugada pattern. We screened the family and actually identified 2 relatives in Boston. Her nephew, who's an EMT, who had his first EKG and had a type 1 Brugada pattern and got a defibrillator, and his dad, who had syncope and a funny EKG, who got a defibrillator also. So again, the family where it took the second sudden death to pick up, sort of Brugada syndrome, that ideally should have been picked up at the first sudden death. So to summarize, Brugada syndrome is sort of depolarization, reduced depolarizing currents, leading to ST elevation in leads V1 to V3, arrhythmias, and sudden death. I'll just say a minute about catecholaminergic polymorphic VT. These are mutations in the calcium release mechanism, the sarcoplasmic reticulum that releases calcium and causes contraction. So you get spontaneous abnormal release. This happens when there's more calcium, which happens at faster heart rates during exercise when adrenaline, epinephrine, norepinephrine are now mutations in the ryanine receptor or the calcium sequestering protein calsequestrin. You get bidirectional ventricular tachycardia, which are PVCs of alternate morphologies strung together to cause ventricular tachycardia. Presents the same way as the other inherited arrhythmia syndrome, except you can bring it out with either an exercise test or beta adrenergic infusion. Beta blockers work. Interestingly, calcium channel blockers do not work at all. Defibrillators work, but the adrenaline surge from a defibrillator can precipitate more VT. Turns out flecainide and other drugs in that class are actually stabilizers of this SR calcium release channel. So flecainide and beta blockers are the treatment of choice if beta blockers don't work with backup defibrillators. Okay, so somebody presents to you with suspicion of one of these inherited arrhythmia syndromes. What do? Well, you take a history. You ask them, have you fainted? Do you have palpitations? Have you ever almost died? You'd think you wouldn't need to ask the last, but actually I saw somebody a few months ago in clinic who was here for this and had given me the history. And at the end I said, is there anything else you should want to tell me? And her husband said, Judy, do you think you should tell him about that time you stopped breathing? And I said, yeah, why don't you tell me about that? And he said, well, we were watching TV and all of a sudden she slumped over and turned blue. And, I started CPR, but then she woke up and we decided not to go to the doctor. And my response was, what type of defibrillator would you like? Anyways, family history of sudden death and inherited syndromes, but also family history of cardiomyopathies, because there's overlap syndrome, family history of pacemakers, defibrillators, family history of sudden infant death syndrome, family history of late-term miscarriages. You look at an EKG, look for long QT syndrome, short QT. You can pick up Brugada syndrome. You can pick up the myopathies as well. Echo and MRI to rule out the hypertrophic dilated cardiomyopathies, arrhythmogenic cardiomyopathy. Stress test will help you pick up long QT1, the one where the action potential doesn't shorten appropriately, and catecholaminergic polymorphic VT. You can do drug testing, isopril for CPVT or dobutamine, and sodium channel blockers for Brugada syndrome, and program stimulation, maybe not all that useful. Treatments range from nothing to avoiding medication to avoiding competitive sports to drugs like beta blockers and defibrillators, and occasionally even VADs and transplants if there's nothing that you can do otherwise for them. Defibrillators, high risk. And what does high risk mean? In this case, probably about 1% a year risk of sudden death is the threshold for defibrillator, especially now that we have sub-Q defibrillators with lower, sort of incidence of long-term complications. If you're 75 with heart failure, you need a 5 to 6% year risk of sudden death to warrant a defibrillator. But if you're 20 years old, 1% a year per year for the next 50 years, and somebody who's otherwise healthy, warrants a defibrillator, sort of these days. And it'll be paid for, by insurance companies, sort of, the criteria are relatively lax for paying for it. Okay, what do you do if you identify somebody with it? Do you screen their relatives? It's a class 1 indication by the AHA and the ACC. So you do what we call cascade screening. So if you find somebody who has it, you look at their closest relative, ideally first degree relatives, parents, siblings, kids, screen them. If you find somebody who's positive, you do their parents, siblings, kids, and you march through the family. Anybody anywhere in the family who's a blood relative who's symptomatic, you should screen. You screen with the test that's appropriate, EKG, obviously, for all the inherited arrhythmia syndrome, but some of them Holters, some of them stress tests, etc. There are some genes that, if you have a whole exome or whole genome screening, like for a funny looking kid, if you identify a mutation, it has to be reported. So some people will be told they have mutations and they'll be otherwise asymptomatic and just show up at a cardiologist or an electrophysiologist. There's questions on whether you should screen all kids or all, people going for athletics. And, I won't get into that right now. We sort of do it at the University of Iowa. We do some screening, when people join these sports teams, and, again, the question, is it really more risky to be playing, basketball in a stadium in front of 10,000 people with an AED or versus a pickup basketball game with 3 friends? And so the answer to that's not exactly clear. Genetic testing, if you show up with definitive clinical long QT or CPVT or most of the other conditions, there's at least a 50-50 chance we'll identify the gene that causes it. Genetic testing is basically reading the book. You do it always in somebody who has the condition. You want somebody who's clinically definitely affected, and it's a blood test. It costs a few $1,000s, but it's usually covered by insurance now. There's different ways to do the genetic testing, but it doesn't really matter. They all work. Sometimes you get these variants of uncertain significance, so you'll find something you won't know for sure whether it's causative or not, and that's a problem. But the pickup rate of a definitively causative mutation is actually pretty good now. Once you identify a mutation, you then test family members, except now it's a simple $200 blood test instead of EKGs and Holters and stress tests and echoes and MRIs and that sort of stuff. So you do carrier testing and you do cascade screening through the family the same way you would on the clinical side. The advantages of genetic testing is you identify who is at risk. And probably the single best use of genetic testing is if you know the gene that runs in a family and you identify somebody who doesn't have it, you can tell them you don't have to worry about it. You don't need clinical screening every 5 or 10 years. You don't have to worry about passing it on to your kids. Hopefully some days there'll be gene-based therapies that we can do as well. We do a little bit. We have beta blockers for some types of long QT syndrome. The problems, the genetic testing is still expensive. It's not always covered by insurance. It does get in the way of getting life insurance. A negative test in somebody with long QT syndrome clinically is useless. You still have long QT syndrome, just the test isn't good enough to pick it up. We don't know what to do with variants of uncertain symptoms significance. We oftentimes don't know what to do with asymptomatic carriers, whether to treat them prophylactically with drugs, whether not to. You can damage people's careers and insurability. And this is a new field and things can still be wrong. And these are the genetic testing labs that are available in the US. And with that, I'll stop. Thank you all very much.
Okay, great. That was terrific, Dr. Lennon. I'm looking at the chat and I don't see any questions there. And since we are a little bit over time, I'm going to propose that if somebody does have a question, you email me or Dr. London or the organizers, Randy Burt or Amy Black, with your questions, and we'll get them to Dr. London and get you your answers back. And so otherwise, I think we're going to close up shop. Thank you, Dr. London.
Thank you very much.